Yes, absolutely perfectly clear, sir. So, with all your due permission, we are beginning with the session for today. Good evening, everyone. This is Batul, the moderator from IGCP, and I'd like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. So, on this World Brain Day, we'll be talking about the topic, which is clinical features and management of diabetic neuropathy. And to talk about this topic, we have none other than Dr. C.S. Narayan, sir. Sir is MD in Medicine, DM in Neurology, Chairman at Manipal Institute of Neurosciences, Delhi. With Sir's wonderful insight, we are going to talk about this topic. But before moving on to today's topic, let us have a brief look on what the topic says. So, in this insightful webinar on clinical features and management of diabetic neuropathy in honor of World Brain Day, in this event, we'll be delving into the complexities of diabetic neuropathy, a common and often debilitating complication of diabetes. And now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you so much. Thank you so much, Batul. Good evening. I work as chairman of the Institute of Neuroscience in Manipal Hospital in New Delhi. Greetings from this hospital. So we'll be covering this topic of diabetic neuropathy under the following heads today: the etiopathogenesis, classification, clinical features, diagnosis, and then move on to the treatment of this condition. As per the International Diabetes Federation, there are 425 million people worldwide who have diabetes. And a staggering statistic is that 115 million of these people live in China, 73 million in India, and 30 million in the United States. But this is dwarfed by the number of individuals who have pre-diabetes, which is even more common, which is estimated to be 388 million in China, 133 million in India, and 85 million in the United States. There is a higher incidence of neuropathy in patients with type 2 diabetes. However, the prevalence is similar for both type 1 and type 2 diabetes mellitus. This is because because of secondary to multiple factors, including differences in the age of onset of diabetes and differences in the underlying pathophysiology. So, diabetic neuropathy is one of the most common chronic complications of diabetes. It affects various parts of the nervous system. It has diverse clinical manifestations and it occurs in a variety of forms: proximal neuropathy, autonomic neuropathy, focal neuropathy, and peripheral neuropathy. I'll be speaking about all this in a little more detail in the subsequent slides. And the most common presentation of these is distal symmetric polyneuropathy. Diabetic neuropathy impacts approximately 30 to 50% of individuals with diabetes mellitus. And as we noted earlier, since the burden of diabetes is so large, there is a vast number of patients that we encounter in our clinics with this complication. The prevalence of neuropathy in newly diagnosed diabetes is 8%, reaching over 50% in patients with long-standing diabetes mellitus. So as we see, about 8% have this complication even at presentation. It contributes to 80% of persons with foot ulceration, and it is also responsible for 50 to 60% of those who have non-traumatic limb amputations. What are the risk factors of this ominous condition? The duration of diabetes and HbA1c are the major predictors of diabetic neuropathy. A number of metabolic syndrome components such as hypertriglyceridemia, hypertension, abdominal obesity, and low HDL levels are consistently associated with diabetic neuropathy in patients with type 2 diabetes mellitus. Smoking, alcohol abuse, and increased height in older age are also some other risk factors. As we all know, Indians have this strange thing called abdominal obesity, whereas Westerners who are obese generally put fat around their hips. So this kind of an apple type of a structure is actually a sugar factory and contributes to this metabolic syndrome. What about genetics? Does it play a role? Yes, several genes are linked to diabetic neuropathy, but only the angiotensin converting enzyme gene and the MTHFR encoding the methylene tetrahydrofolate reductase enzyme polymorphisms have been studied in multiple populations, including large cohorts. So, though there is an association, it is not very clear cut. What about metabolic abnormalities? There are several metabolic abnormalities which contributes to the development of neuropathy in persons who are diabetic. The most important of which is what we call the polyol pathway. There is an increased glucose flux through the polyol pathway, which leads to intracellular accumulation of sorbitol and fructose, resulting in a cellular osmotic stress and oxidative damage. The second important metabolic factor is the presence of advanced glycation end products. Excessive glucose in the body reacts with proteins to form advanced glycation end products, which cross-link and impair nerve function. The third contributing factor is oxidative stress. There is an enhanced production of reactive oxygen species, which overwhelms the endogenous antioxidant defenses, leading to nerve cell injury. The last contributing factor is mitochondrial dysfunction, which impairs and disrupts cellular energy metabolism and thus exacerbating nerve damage and dysfunction. So these are the putative mechanism by which diabetes causes neuropathy. The polyol pathway, the presence of advanced glycation end products, oxidative stress, and mitochondrial dysfunction. So this is a graphic which appears to be busy in the first glance, but it only amplifies what we have said in the previous slide. So there is a presence of increased glucose, which is metabolized the polyol pathway or the hexosamine pathway or glycolysis. And subsequently, they all cause osmotic stress and the increased amount of reactive oxygen species and further causing endoplasmic reticulum stress and DMA damage. The second factor is the presence of dyslipidemia in diabetes, and this also causes the presence of inflammatory signals and ultimately leads to apoptosis and cell death. So this is a graphic which appears to be busy, but it is very important in understanding the multiple mechanisms by which diabetes causes neuropathy. There is also reduction in neurofilament, GAP43 and beta tubulin synthesis, and increased heat shock protein and PRP expression at the level of the dorsal root ganglia. There is ischemia of the nerve cells and the axons. There is demyelination in more severe cases, which in turn causes degeneration and disruption of axon transport. This is the mechanism by which myelinated fibers are affected. Diabetes, as we all know, can also affect unmyelinated fibers, which are the C fibers and the A delta fibers, which is primarily responsible for the painful component of diabetic neuropathy. The axonal or the myelinated part of this neuropathy usually causes loss of tendon reflexes and loss of proprioception and balance. Another mechanism which causes and contributes to diabetic neuropathy is vascular insufficiency. There is endothelial dysfunction, which causes microvascular changes that impair blood flow and nutrient delivery to peripheral nerves, leading to increased tissue hypoxia and nerve fiber degeneration. Hypoxia and ischemia and the reduced oxygen supply exacerbates the oxidative stress and contributes to the nerve damage. Along with this, there is neurovascular inflammation. Inflammatory mediators, immune cells infiltration further disrupt nerve function and perpetuate tissue injury. So as we have seen in the last couple of slides, there are multiple mechanisms which may cause this and may lead to the aggravation in some persons, and if all the factors are not in play, some persons may escape the onset of diabetic neuropathy. What are the neuroinflammatory responses? There is immune cell activations. Macrophages and T lymphocytes infiltrate the nerve tissues, releasing pro-inflammatory cytokines and exacerbating neuroinflammation. There is cytokine production. TNF alpha, IL-6 and IL-1-2B contribute to the neuronal sensitization and pain hypersensitivity. Lastly, there is glial activation. Reactive astrocytes and microglia in the CNS perpetuate neuroinflammation and contribute to neuropathic pain. As we've seen, firstly, there is axonal degeneration, and this goes pari passu with demyelination. So, demyelination is not present in all patients, but some of them do subsequently go on to develop demyelination. There is impaired axonal transport, which disrupts the mechanisms that lead to neurotrophic deficits and distal axonal degeneration. Demyelination causes the loss of myelin sheath integrity and impairs nerve cell conduction velocity and exacerbates sensory motor deficits. Ultimately, there is also Wallerian degeneration that contributes to functional impairment and neuropathic symptoms. So, something that we have briefly touched upon in the introductory slides is in what are the various manifestations of this diabetic neuropathy. Firstly, you can have distal symmetric sensory motor polyneuropathy, which is the most common and which happens in a glove and stocking distribution as you see in this graphic. Secondly, you can have asymmetric neuropathy, which can present in the form of lumbosacral neuropathy or proximal neuropathy affecting the thighs. Otherwise, you can have entrapment neuropathy affecting various nerves. Here we see in this graphic median nerve neuropathy presenting as carpal tunnel syndrome. You can have ulnar neuropathy or peroneal entrapment neuropathy. Diabetic neuropathy can also present with autonomic neuropathy that involve the heart, the stomach, and the viscera, including the large intestine, the small intestine, and the bladder. And these also present variously with different symptoms that we will be touching upon in the next few slides. So, as we have said earlier, distal symmetric polyneuropathy is the most common form, and this is characterized by symmetric sensory, motor, and autonomic nerve dysfunction in the distal extremities. There could be mononeuropathy, wherein there is focal nerve damage affecting individual nerves, such as cranial nerves. This is very common, which can present as facial nerve paresis, and in many cases, a sixth nerve paresis or third nerve paresis, causing abducens paresis and ptosis. They could also involve the peripheral nerves, as we said, causing the carpal tunnel syndrome, which is a very common manifestation of diabetic neuropathy. Acute painful neuropathy is the rapid onset of severe neuropathic pain, often associated with proximal neuropathy, which is also called diabetic ametrophy, wherein there is wasting of the thigh, and this is supposed to be an immune-mediated problem, and this is somewhat responsible to immune media with treatment for suppressing the immune-mediated processes. Autonomic neuropathy is another manifestation, and this can present as cardiovascular autonomic neuropathy, which impairs the heart rate variability. It causes orthostatic hypotension and exercise intolerance. Gastrointestinal autonomic neuropathy can cause gastroparesis, constipation, diarrhea, and fecal incontinence. Genitourinary autonomic neuropathy can cause erectile dysfunction, neurogenic bladder with urinary retention or incontinence, and altered sexual function. As against the peripheral manifestation of neuropathy, unless we ask pointed questions, we may sometimes miss these manifestations of diabetic neuropathy because the patient may not volunteer these symptoms unless they are asked for directly. As I said, diabetic ametrophy is not uncommon. It is selective damage to the nerves in the thighs, hips, and buttocks, resulting in asymmetric motor weakness and severe pain. As we see in this graphic, there is severe wasting of the right thigh as compared to the left. The second type of proximal neuropathy is thoracoabdominal radiculopathy, which can cause painful radiculopathy affecting the thoracic and abdominal regions, often associated with weight loss and muscle wasting. Focal neuropathy, as we mentioned, can be cranial neuropathy, which causes sudden onset dysfunction of cranial nerves, presenting as facial nerve palsy, oculomotor nerve palsy, or trigeminal neuropathy. The important thing to note about cranial neuropathy it is that it is painful, but it is also self-limiting, so we can reassure the patients that with time, maybe in a few weeks to a few months, they can expect significant improvement in both the pain and the paresis of these cranial nerves. Peripheral nerve entrapment can cause compression neuropathies such as carpal tunnel syndrome, ulnar neuropathy, and entrapment of nerves in other specific anatomical sites such as the cubital tunnel. What about the sensory symptoms? These include paresthesia, which can present as tingling, burning, or electric shock like sensation in the extremities. Numbness, loss of sensation, particularly in the hands and feet, is very common. So is allodynia, which is a painful response to non painful stimuli such as light touch or even if some kind of a clothing brushes on that particular part. So the sensory symptoms to summarize are burning, shooting, and electric-like pain, hyperalgesia, which is enhanced perception of pain, allodynia, wherein a non-painful stimulus is perceived as pain, paresthesias, numbness, poor balance, and falls. All of these contribute significantly to the morbidity of these patients. What about the motor symptoms? The motor symptoms can cause difficulty in walking, climbing stairs, or performing fine motor tasks due to muscle atrophy and weakness. There could be foot drop with inability to dorsiflex the foot and which results in the characteristic high stepping gait. Autonomic symptoms that we said can cause orthostatic hypotension, resting tachycardia, and extra intolerance. Gastrointestinal symptoms can cause gastroparesis, constipation, diarrhea, and fecal incontinence. Genitourinary symptoms are erectile dysfunction, neurogenic bladder, and decreased libido. So, in a diabetic who presents with these symptoms, do they all have diabetic neuropathy? Mostly yes, but we must consider some other conditions which can also present with neuropathic symptoms in these patients. These are the associated use of alcohol, nutritional deficiencies, especially low B12 and high B6 levels, Guillain-Barré syndrome, especially if there is a subacute presentation, toxins, drug overdose, chemotherapy can also cause symptoms of neuropathy in persons who are diabetic. Hereditary or genetic conditions such as the Charcot-Marie tooth, amyloidosis, and porphyria can also present with neuropathy in diabetics. HIV, which has become much less common these days, inflammatory conditions such as SLE, rheumatoid arthritis, hypothyroidism, and malignancy would complete the list of differential diagnosis. So, what are the red headings which would tell us that the patient is possibly not having diabetic neuropathy but neuropathy due to some other cause? As I said, an acute or subacute presentation is uncommon in diabetic neuropathy, and it is more common in neuropathies such as Guillain-Barré syndrome or CIDP. When the neuropathy is non-length dependent, as we know, peripheral neuropathy in diabetes is Glavin-Stocking because it is length-dependent neuropathy affecting the longest nerves in the body first. And usually, the neuropathy in diabetes is sensory motor, affecting both the sensory component, motor component, and as we've also discussed, the autonomic nervous system. However, if there is only motor predominance, we should think of other causes and also asymmetry. Though, as we've said, in some diabetic neuropathy, there is asymmetry. The vast majority of diabetic neuropathies are symmetric. So, what do we do to screen out the other causes? So, there's a very simple formula. Firstly, we must take a family and a medication history. We must estimate the serum B12 and folic acid levels, a simple blood count, thyroid function, metabolic panel, a serum protein immunoelectrophoresis, ANA, CSF examination when warranted, genetic testing when warranted, and as a last resort, nerve biopsy. So all these things put together, and not all these are required in all patients, can rule out almost completely the other causes of neuropathy in patients who are diabetic. What are the non-diabetic neuropathies common in diabetes mellitus? As we said, the more common neuropathies are pressure palsies, CIDP, radiculoplexus neuropathies, and small fiber neuropathies which are treatment induced and not related to diabetes. So how do we evaluate these patients clinically? We should take a detailed medical history which would include the assessment of diabetes duration, their glycemic control, and the onset of neuropathic symptoms. We must examine them, and it will include a neurological assessment for sensory deficits, motor weakness, and autonomic dysfunction. Foot examination is very important and a very neglected component, and we should examine for foot ulceration, infection, and then also their peripheral vascular status, which can exacerbate the already existing neuropathic symptoms. Neurophysiological testing is a very important component of assessment of diabetic neuropathy. This includes nerve conduction studies for nerve conduction velocity and amplitude to detect axonal loss and demyelination. It is very easy to distinguish between the two. I will not delve into the details of that. EMG may contribute in some patients, and so also quantitative sensory testing for the assessment of sensory thresholds to quantify neuropathy severity and to monitor disease progression. The common tests for assessment of neuropathy: if we suspect large fiber neuropathy, one must do nerve conduction tests. And nerve conduction tests are the gold standard for this. They're sensitive, specific, and reproducible, and it can be easily done in any neurology or neurophysiological laboratory. When we suspect large and small fibers, then there is a neuropathy disability score which can help us in assessing the disability. When we suspect only small fiber neuropathy, our nerve conduction studies fall short because they're not so specific and sensitive for this. Then we must resort to quantitative sensory testing. We can do skin biopsy or a corneal confocal microscopy. These are very rarely done, but these are more specific for the presence of small fiber neuropathy. Imaging studies like MRI and CT can help in further delineating the presence of pressure palsies like the carpal tunnel syndrome, and so also ultrasound. Again, with our clinical acumen and with the support of very common tests like neurophysiology, these are rarely needed. And advanced diagnostic modalities like skin biopsy for the assessment of intraepidermal nerve fiber density for small fiber neuropathy, rarely done, but it is a research tool and one must be aware of it. Autonomic function tests are very helpful in the evaluation of cardiovascular reflexes and pseudomotor responses to detect autonomic dysfunction, and when available, we must definitely take their help. Coming to the management, does good glycemic control prevent diabetic neuropathy? In type 1 diabetes, where I said neuropathy is not so common, good glycemic control definitely helps. Unfortunately, the data does not support that if we, even with good glycemic control, type 2 diabetes and neuropathy can be treated very well. So we must resort to some pharmacological interventions, which include analgesic agents. We must start off with non-opioid analgesics like NSAIDs and acetaminophen with some discretion. We must not overuse them. More importantly, we take recourse to anticonvulsants and antidepressants like gabapentin, pregabalin, amitriptyline, duloxetine. These agents are very, very good, and they must be started in low doses, and the dose must be stepped up so that the patient achieves a good kind of tolerance to these medications and are able to, there is very little dropout from the treatment. Neuroprotective agents like aldose reductase inhibitors, antioxidants, and neurotrophic factors to mitigate nerve damage are commonly used, but research does not support the use consistently. But since for want of other agents, I do use them quite routinely. What about lifestyle modifications? We did say that blood sugar control should be done. If not for the management of neuropathy only in diabetics, it has so many other benefits. So we must have a proper blood sugar control through diet, exercise, insulin therapy to prevent further nerve damage. Smoking cessation, elimination of tobacco are used to reduce oxidative stress and improve vascular function. A healthy diet consisting of low carbohydrate, nutrient rich diet to maintain optimal metabolic health, and regular exercise, aerobic, and resistance training to improve blood flow, nerve function, and overall fitness. There's some rehabilitation strategies like physical therapy, which include strengthening exercises, balance training, and gait training to improve mobility and to reduce the risk of falls. Reduction of falls is very, very important in the elderly. Occupational therapy, like adaptive techniques and assisted devices to optimize functional independence. Pain management techniques will include transcutaneous electrical nerve stimulation, TENS, acupuncture, and massage therapy. When these do not work, we can take recourse to interventional procedures like peripheral nerve blocks, like with local anesthetics or steroid injections to relieve localized pain and inflammation, particularly in the context of lumbosacral neuropathy. Spinal cord stimulation with implantation of electrodes along the spinal cord to modulate pain signals and improve signals is also useful in a minority of patients. What about some emerging therapies? Regenerative medicine with stem cell therapy, gene therapy, and growth factor administration to promote nerve regeneration are on the cusp of development, and I'm sure and I'm very confident in the near future they would be translated from the research lab to clinical practice. Neuromodulation with peripheral nerve stimulation, dorsal root ganglion stimulation, and deep brain stimulation offer hope in refractory neuropathic pain. Biomedical devices with wearable sensors, prosthetics, and orthotics can enhance sensory feedback and functional outcomes. Along with all this, patient education and support is very important. They must be educated on foot care, symptom monitoring, and most importantly, adherence to medication. Psychosocial support in the form of counseling, cognitive behavioral therapy, and support groups to address the emotional and aspects of living with diabetic neuropathy needs a lot of attention. Targeted molecular therapies, which involve inhibition of the polyol pathway, the advanced glycation end product breakers, and mitochondrial modulators, are also being developed. Like I said, stem cell transplantation, gene therapy are also being actively pursued. In conclusion, I would say that diabetic neuropathy is a complex and multifaceted complication of diabetes mellitus, characterized by nerve cell damage and dysfunction, a comprehensive understanding of the pathophysiology, classification, clinical manifestations, diagnosis, advanced management strategies, emerging therapies, and ongoing research efforts is essential for optimizing patient care and outcomes. Thank you ever so much.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform and for making our viewers understand about it. Thank you so much for that. We have received few questions from the participants. So, with all your due permission, I would like to put across those
Sure,
questions
most
to you.
welcome.
Yeah. So, the first question is related to autonomic neuropathy. So, how do autonomic neuropathy and peripheral neuropathy present differently in diabetic patients?
So, as I said, peripheral neuropathy can have multiple manifestations, the most common of which is distal symmetric polyneuropathy, which is in a glove and stocking distribution. And this can present with pain and paresthesia, whereas autonomic neuropathy usually affects the heart, the visceral organs, or the urinary bladder. Exercise intolerance and heart-to-heart rate variability is a one, and fluctuation blood pressure, the manifestations of the autonomic neuropathy affecting the heart. In the if it affects the gut, there could be constipation, diarrhea, or diarrhea alternating with constipation. These are very common. Or there could be gastroparesis, wherein there is poor digestion in these patients, and they can have repeated vomiting. If they involve the bladder and the sexual organs, they could have libido or failure to ejaculate, or they can have incontinence or various other symptoms related to the urinary bladder.
Thank you so much, sir. Thank you for
And
answering.
as I've said, they can coexist as well. One type of neuropathy does not preclude the same person from having different types of neuropathy.
Thank you so much, sir. Thank you for answering that question. Moving ahead with another question. The next question is: how can diabetic neuropathy contribute to the development of diabetic foot ulcers?
So, the sensation in the foot is a very important component of preventing injury to the foot. So, it is very common for, particularly in our country, if a person does not wear a footwear and goes out and walks on a hot road surface in the village, so they're not able to perceive either the heat or the roughness of the surface, and they constantly subject to injury to the foot, and these little ulceration ultimately kind of enlarge, become bigger and bigger, and contribute to the foot ulceration, and may actually ultimately result in catastrophic amputation. And along with the neuropathic component of this foot ulceration, an important contributor is the vascular component. So whenever a diabetic presents to your clinic, we must examine the foot both from the neurology angle and from the vascular angle, which is both are very simple. The neurology testing include the testing of sensation. The vascular angle involves the testing of the peripheral nerves.
Thank you so much, sir. Thank you for answering that question. Moving ahead with another question, and the question is related to challenges. So, what are the challenges in meeting optimal glycemic control in patients with diabetic neuropathy?
No, optimal glycemic control has nothing to do with the management of diabetic neuropathy, and glycemic control. Like I've said, are very important in type 1 diabetics. In type 2 diabetics, research has not shown that glycemic control is a very important contributing factor to the progression of the neuropathy. But as I've also kind of said, glycemic control is an independent risk factor for so many other things which happen in patients with diabetes. It contributes to microvascular complications involving the retina, involving the kidneys, involving so many other organs, and the macrovascular complications that result in strokes, in myocardial infarction. So it is a very important component, but the progression of neuropathy itself is not impacted so much by glycemic control in type 2 diabetics. In type 1 diabetics, it is also important contributor.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the last question before we conclude the session. And the question is related to common pitfalls. So, what are the common pitfalls in diagnosing and managing diabetic neuropathy, and how can they be avoided?
So, as I've said, the common pitfalls are not all neuropathies in diabetes are diabetic neuropathies, though the vast majority are. But we must keep our eyes and ears open for some red herrings that I did speak about. Most of the diabetic neuropathies are chronic in presentation, so they evolve over weeks or months to years actually. And whereas if there is a subacute presentation wherein the neuropathy progresses over days or weeks, then we must think of other neuropathies, the most important being the demyelinating neuropathies like AIDP and CIDP. And we also said that the vast majority of diabetic neuropathy is symmetrical. Some neuropathies like diabetic hematopathy or the compression syndromes are asymmetric. The cranial neuropathies are also asymmetric, but these are not very common presentations. Whereas asymmetric presentation is one of the red herrings which would alert us to the possibility of other conditions in a person who's got diabetes. The third one is the diabetic neuropathies in most cases are sensory motor and also can involve the autonomic nervous system. Whereas if there is a pure motor presentation, one must think of other conditions. So there are, like I said, some screening tools which are very simple, well, like the estimation of the vitamin levels in the blood, a complete blood count, certain tests, specialized tests like the lumbar puncture, a nerve biopsy. These are the things, or a ANA or a serum protein electrophoresis. In some certain situation, can help us in differentiating between these two conditions.
Thank you so much, sir. Thank you for answering that question and all the other questions for our viewers and making them understand about the topic in such a better manner with all your wonderful insights that you have shared on our platform. So, thank you so much for that. And I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. And at the outset, sir, I would like to take a last take home message from your end before we conclude the session.
No, it has been my first experience with your platform, and it has really been wonderful. And if I contributed even in a minor measure to improve the understanding of diabetic neuropathy in the vast number of practicing professionals in our country, I'll be really honored.
Thank you so much, sir. Thank you. It was our honor and pleasure, sir, to have you at our platform and sharing the same platform with you. So, thank you so much for giving us this opportunity to serve the population and to you, sir. Thank you so much for that. So, with
Thank you
this,
so
we would
much.
like to conclude the session here for today. Until next time. Thank you, sir.
Thank you. Good night.